Welcome, everyone. Thank you so much for joining us today for this, our second discussion in our series dedicated to psychiatric drug withdrawal. And on behalf of our partners, A Disorder for Everyone, the Council for Evidence-Based Psychiatry, and the International Institute for Psychiatric Drug Withdrawal, we're so grateful to see so many of you join us today. And thank you to all of you who made a donation to be with us today. It's really appreciated, and it really helps us to stage these events and put more of them on. So thank you. My name is James. I'm the host of the Mad in America podcast. And before we get underway with an introduction to the panel, I just want to mention a couple of people behind the scenes who keep things running for us. So firstly, we have Shira Collings, and Shira Collings works for Mad in America Continuing Education, and she's managing the call for us today. Thank you, Shira. And we also have Lucy Fernandez, who will be looking after the chat and the questions. And Lucy is the administrator for the International Institute for Psychiatric Drug Withdrawal. So we have an hour and a half today. First hour is devoted to the panel, and then half an hour for viewer questions at the end. And just to say, the discussion is being recorded today, so if you don't get to see all of it, we will be putting it on our YouTube channel afterwards and sharing a link to it. So please feel free to ask questions, and we'll be selecting some of them for later. We won't be able to address them all in the time that we have, but if there are questions asked that we can't get to, then we'll try and build them into future sessions. So to ask a question, please use the Q&A button at the bottom of the Zoom window. Just because questions placed in the chat might be lost and might not be easy to see. And bear in mind, anything you write in the chat or the QA is visible to everyone. I do also just want to mention that the panel won't be able to respond to individual circumstances surrounding withdrawal. And I know this is disappointing sometimes to hear, but addressing those in this kind of format would be very hard because of all the complexities and intricacies. And before we go any further, it's very important to say that if you are someone considering coming off your psychiatric drugs, please never stop your drugs suddenly. If at all possible, please seek advice and support from a knowledgeable professional. So the panel today and for future discussions are not providing medical advice or making specific recommendations regarding withdrawal. Our aim really here is to explore and discuss. For those of you watching that might be new to these issues, we do have a page on Mad in America with some resources and links, and you can find this by visiting the website madinamericacom/PDW, and we'll put that link in the chat so you can find it. So I hope that's all okay. As I say, we're delighted to have you with us, and so I'm onto the panel now. I'm really pleased to say that we have with us some of the world's premier researchers in this particular field. And so without any further ado, I'd like to ask the panel members if you could introduce yourselves and say a little bit about how you became involved in withdrawal-related research. So Joanna, could we start with you?
Yes, hello James, thank you for inviting me, and thank you everyone for coming. It's fantastic to see people from all over the world. It's a great boon of our current circumstances. So I am a psychiatrist, and I've always been interested in psychiatric drugs and what they do to people, and trying to understand trying to understand them from a different perspective and interrogate the way in which they are generally presented in the psychiatric field. So that's really what led me into withdrawal. Obviously, when you're trying to understand everything that a drug does, you become curious about what happens when someone's taking the drug for a long period and when they stop it, and what goes on after that. So that's my background. I'm now, after many years, a professor at University College London, as well as still practicing as a psychiatrist in the NHS in London.
Perfect. Thank you so much, Joanna. Peter, could we come on to you next?
Yes, you can. I've got a short introduction. My name is Peter Groot, and my educational background is that I studied chemistry, and this was followed by years of molecular genetic research at different institutions, both in the Netherlands and the US. And I obtained a PhD in 1989, and in 2012, as part of a part-time study, I also got a bachelor in psychology. Now, my interest in psychiatric drug withdrawal stems from the fact that in 2004, I started using antidepressants myself. And I decided to do this at that time because I was very depressed and I saw no other options. Now, in an attempt to find out if antidepressants worked for me, for a long period of time, I measured my own mood and I wrote about it. And one of the things I discovered during this period was that I experienced withdrawal every time I forgot to take my daily dose of venlafaxine. And this started me to realize just how big and overlooked withdrawal problems were and still are. And in a strange and very unpredictable and surprising way, this realization has led to the development of so-called tapering strips. We will hear more about this, I guess, later. And I have described how this happened in a recent review, so I will not elaborate on this here now. Now, my first goal, and I think the goal of the people I work with, but I think also the goal of many service users all over the world, was to find practical solutions for tapering and dose optimization. Solutions that will truly help doctors and patients. Solutions which, in my opinion, should be based on shared decision making and on proper monitoring and self-monitoring. And my second goal was and still is to do withdrawal research, obviously using tapering strips, which is also the subject of tonight's town hall. And my hope is that this research will help to further improve the current practice of tapering. And I think for the rest, I will just answer questions when they come around.
Okay. Thank you, Peter. Thank you. That's great. And Mark, could we go on to you next?
Sure. So I'm Mark Horowitz. I'm a training psychiatrist, and thank you very much for inviting me. It's great to be on this panel with everyone else. I did a PhD in psychiatry. I was a fairly conventional psychiatrist, I would say. I did a PhD in the neurobiology of depression and the way that antidepressants affect the brain by looking at brain cells in a dish. I had no intention of going into withdrawal research until I had a very short, sharp, painful introduction into the topic of withdrawal by trying to come off escitalopram after being on it for many years, an antidepressant. And I quickly worked out, by reading Giovanni's work, that what had happened to me wasn't rare and it wasn't isolated. And also that the academics and psychiatrists that I'd studied under had very little to say that was useful about how to come off these drugs. And in fact, many of them tried to minimize the scale of the problem. And I ended up going on peer support websites to get advice on how to come off the drugs safely. And I learned a lot from people like Adele Framer, who runs Surviving Antidepressants. And since then, I've spent my time trying to write articles and explain to doctors and other people what is the safest way we think to come off psychiatric drugs, including antidepressants and antipsychotics and other drugs. And I also have the privilege of working on the RADAR trial with Joanna, in which we're taking people off antipsychotics slowly, and we're also looking at ways of implementing safe tapering into the public health system in England in the NHS. That's me.
Thank you so much, Mark. And Giovanni, welcome. If you could tell us a little bit about you too, that would be great.
Yes, thank you. I'm a psychiatrist, and I'm a researcher, but unlike most of my colleagues, I actually evaluate and personally treat a lot of patients. I have joint appointments at the University of Bologna in Italy, at the University at Buffalo in New York. And early 90s, I started seeing patients clinically with problems related to antidepressant drugs, particularly withdrawal reactions, which were not really recognized in the literature. In addition to being a clinician and a researcher, I'm also the editor of a journal, Psychotherapy and Psychosomatics, that allowed me to write an editorial back in '94, raising questions about antidepressant, which was actually the beginning of some questioning. Bob Whitaker took the editorial and became a chapter of his book, Anatomy of an Epidemic. And since then, so it's been a long time, been doing research and reviews on these topics, and also trying to point to issues in our journals that other journals would not allow to be published. I think.
Thank you. Thank you. We're thrilled to have all of you with us, and for the next part, really, it would be nice if we could perhaps delve into a little bit more detail about your individual areas of research and speciality, and I hope that will kind of give people a sense of where we're making progress in this particular area. So it would be good to maybe, if it's okay, Mark, to start off with you to talk a little bit about your work with hyperbolic tapering and serotonin occupancy, if that's okay.
Sure. So I thought I'd talk for 5 minutes about the basics of drugs and tapering that I'm sure other people will take forward. So I think psychiatric drugs have effects on the brain, and the brain responds to that by adapting to try to minimize those effects. That's what the brain and body do to stimuli. When it's too hot, the body tries to cool us down. When it's too cold out, it tries to warm us up. And so over time, the brain changes in response to taking psychiatric drugs, involving up or down regulation of receptors and other changes we don't quite understand yet. And so your brain gets used to a certain amount of stimulation from the drugs. When you stop the drugs, the difference between what the brain expects and what it's receiving is experienced as withdrawal symptoms. And we know that from drugs like nicotine or caffeine or certain recreational drugs. And it seems to be the same for psychiatric drugs. So that means for antidepressants, for benzodiazepines, Z drugs, gabapentinoids, mood stabilizers, and antipsychotics. And so what we know is the worst possible way to stop a psychiatric drug is to stop it suddenly in one day. Your brain is used to a certain level of stimulation. The drug completely goes out of your system, and that difference is experienced as withdrawal symptoms. Something like jumping off the top of a 10-story building down to the ground floor, and it can cause extremely severe withdrawal effects in some people. So the opposite of jumping off the 10-story building is coming down step by step through every floor. And that's what tapering is. Tapering is making small reductions spread out over time so that each reduction is tolerable, either mildly unpleasant, but not intolerable, or for some people not unpleasant at all. And what that does, we think, is it gives time for the brain to get used to less effect of the drug. So rather than dropping down like that, you go down a little bit, the brain has some time to adapt to the new level, and you keep doing that, and you can go all the way down to zero in that manner. And so what people would normally do in practice is, say, reduce someone's dose by 5 or 10 or 20%. It varies as to what people can tolerate. And then observe someone for withdrawal symptoms, which might happen a few days after a reduction, might increase in intensity, reach a peak, improve, and go back down to near normal. That might take someone 2 or 4 weeks, depending on how big the reduction is. And based on how someone deals with that reduction, you can keep on making reductions and go down all the way from your starting dose to the bottom. It will vary greatly as to how long that process needs to take for people. So for some people who are on the drug only for a short number of weeks or months, it might be possible to come off a drug in a few weeks. But if people are on a drug for years, then it might take people months or even years to come off a drug in a way that's tolerable and doesn't cause too many withdrawal symptoms. And then the last thing to think about is how to make those steps down from the 10th floor building equal in size. And so you might think that to make an equal size reduction in effect on the brain, you would need to make equal size reductions in dose. So I'm just going to share my screen briefly for one slide. So this is an example of an antidepressant and its effect on the brain. And what you can see is that dose of an antidepressant doesn't linearly increase effect on the brain. It actually goes up very steeply in terms of its effect on the brain, and then it levels out. And that's actually true for all psychiatric drugs. And what that means is if you reduce your dose in a linear way, 20 milligrams to 15 to 10 to 5 to 0, each of those steps produces an increasingly big effect on the brain. So you can see this final reduction is actually a huge decrease in effect on the brain. And so while the first reduction might be reasonably tolerable because it doesn't cause that big a change to the brain, the last reduction can be very difficult to make and cause severe withdrawal effects. And so what this also helps you to predict is if you want to make even size reductions in effect on the brain, you've got to make smaller and smaller size reductions of dose. So you can see each of these size reductions in dose produces the same effect in reduction in terms of effects on the brain. And what that means is the final dose before completely stopping will have to be extremely small. So in this case, for example, less than 1 milligram of an antidepressant, and that's true for lots of different drugs. And this pattern of tapering can be described as hyperbolic, which is just a fancy way of saying getting smaller and smaller as you get down to total lower doses. And so those are sort of the things that I focused on in some of my papers. Thanks.
Great, thank you, Mark, and that's very helpful because I think it kind of explains to people why they might struggle in the very final stages of their withdrawal. It's a common question, isn't it? Why does it get so tough at the end? And I think your work really nicely brings out why it gets so hard at the end for people.
Thanks.
Great, thank you.
Stop sharing.
Okay, and Peter, I wondered if we could turn to you and talk a little bit about your development of tapering strips, which, you know, kind of quite neatly tie in with Mark's explanation there of, you know, how we need to adopt a slow and steady approach to helping people to come off. So if you could talk a little bit about your tapering strips work, that would be marvelous.
Well, I gladly do this. Well, to begin with, what Mark is describing, if you think about it, this is what so many patients over so many years have been trying to do themselves at home, desperately fiddling around with their own medication to make these steps smaller. So they clearly realized that this was necessary. And I think the realization that the steps near the end had to be small was also there. And what Mark was doing when his paper appeared, I was extremely glad because what he described was what we had been trying to make possible starting in 2013. And the idea we had was very, very simple. It was the same idea all these patients were having, and it was actually based on the idea of somebody, a Dutch person who wrote it down in 2004. And that was to make a strip with tablets of ever smaller dosages. Now, we tried to make this, but we realized this was practically a very difficult way of doing it because you need so many different dosages. It's prohibitively expensive. So instead of making many different dosages, we only make a few different dosages, just like the system you use when you are paying with money. We have coins of 1 cent, of 5 cents, 10 cents, of 20 cents, and we don't have coins with 17 cents or 13 cents because we don't need them. And the thing we did, and it's basically very simple, is make a strip. This is what we call this tapering strip. And as you can see, I hope you can see this, the number of tablets in this strip differs from day to day, as does the size of the strip, the size of the tablets. But the amount, the total dose for a single day can be reduced very, very gradually. And in fact, by doing that, we can do what Mark is proposing with his hyperbolic tapering. So you can go faster in the beginning and slower in the end. And one of the things, and I want to stress this, that we have come to realize more and more in contact with patients, is the extreme variability between different patients. So if I answer questions on the website in the Netherlands, Psychosis.net, if I answer questions, I also always try to explain it's basically not very useful to try to set a certain date for this much time I will take to taper my medication, because it's basically impossible to predict it. Some people can stop cold turkey, even with phenylphthalein, without seeming to have much problems, but there are very few people who can do this. Some people will find out that they need much more time. Now, if you can do this with a system in which you can easily have the medication prescribed to you, and you monitor yourself during the tapering, you can experience that you are starting to get some complaints, and this can be a reason to slow down or to increase the dose a little bit, and then together with your prescriber, you can try to get to the end of your taper by being able to adapt during the tapering. And in fact, I think that's what all these websites we have, like Met in America, the Withdrawal Project, and also Heather Aston, have been telling all along. You have to see how it goes, adapt, and try to get to the end. And that's, I think, the only way. And I don't think it will be possible to predict, like, this is the right scheme for this medication. And I think, in fact, this is what we see happening in the Netherlands from the results we get back from patients who have used the tapering strips to take. So I hope this explains or answers your questions for now.
Thank you, Peter. That was helpful. And obviously, we'll come on to kind of delve into some questions on these issues. Turning to you, Joanna, I wondered if it's okay if we could talk a little bit about the drug-centered model and your work on that, and particularly, how it might help change the conversations that we have around people struggling with withdrawal problems.
Yeah, thank you, James. I feel this message to this sort of audience is maybe not necessary, but I do think understanding what the drugs are doing in the first place is an important thing for people to be informed about. More and more research is coming out, which makes it clear that the population, including doctors and GPs, have become convinced that psychiatric drugs work because they rectify an underlying chemical imbalance. And that makes people understandably really, really nervous about the idea of stopping their medication. And I really think it puts people into a fragile and vulnerable state of mind, people who are probably feeling fragile and vulnerable to begin with, and stops people from potentially moving on with their life and trying to get off medication, and also prevents people, maybe people themselves or doctors, from recognizing withdrawal symptoms as what they are. It makes people more likely, I think, to interpret withdrawal symptoms as relapse. So my work has really been trying to explode this myth that drugs are rectifying a chemical imbalance, even if mental health problems are caused by chemical imbalances or other biological abnormalities, and that's not been shown for any sort of mental health problem. But even if they are, we have no evidence that drugs work by correcting those underlying abnormalities or chemical imbalances. And that's because placebo-controlled trials don't discriminate, don't tell you that the drug is working in one way rather than another way. And because there is another very plausible explanation for how drugs are working. So in my work, I've called that idea that drugs are rectifying an underlying abnormality the disease-centered model of drug action. My first paper was published in Giovanni. My first paper on this was published in Giovanni's journal. Thank you for that. And I contrasted that idea, that assumption that has, underlied all use of drugs in psychiatry, or most use of drugs in psychiatry, with the alternative way of understanding psychiatric drugs, which I've called the drug-centered model. And this basically says, well, these drugs are active drugs, active agents that change the normal state of the body and the brain. They're all drugs that cross the blood-brain barrier, and they change the brain in one way or another. So, of course, they're going to interact with any symptoms or problems that people have that are manifested in emotional difficulties, or difficulties with thinking, or behavior, sort of controlling behavior. Just as we recognize, for example, we have a phrase called drowning your sorrows. We recognize that if you are depressed and you have a drink of alcohol, that may well abolish the depression for a short time. The alterations that are induced by taking alcohol are superimposed on your underlying emotional state, unchanged by it. That doesn't mean that anything is happening to the underlying biology of that problem, if that is the right way to think of the problem, which I would argue it's not. So this drug-centered model really highlights that drugs that are prescribed for psychiatric problems are psychoactive drugs, and there's no hard and fast distinction between psychiatric drugs and recreational drugs that have psychoactive effects, apart from the fact that many psychiatric drugs cause effects that are not generally experienced as being very pleasant, whereas by definition, drugs that are used recreationally induce effects that at least some people find to be pleasant. And then I think if you understand that there's no hard and fast distinction, there you start to realize that psychiatric drugs are likely to have all the same sort of problems, therefore, that recreational drugs have. And we recognize with recreational drugs that there is this problem of tolerance, that the longer you take them, the less they have the acute effects that they cause, and the more likely you are to have problems when you stop them, to have withdrawal problems, because of the modifications that the drug has induced in the body and the brain. There are differences between different sorts of drugs, as well as differences between the way that individuals react to them. And just another thing to say is we we really know very little about the sorts of changes that these drugs make in cause to the brain and to the body, and we know very little about what goes on when people stop using them. There's been a little bit of research on opiate withdrawal, the sort of physiology and neurology of opiate withdrawal, but very little on withdrawal from other substances. We do know, however, that sometimes long-term use of drugs can modify in the brain or the body in ways that seem to be quite long-lasting. So we know, for example, we've known for decades that if you take antipsychotics for any sustained length of time, there is a risk of developing tardive dyskinesia, this neurological abnormality, which can last even when the drugs are stopped, sometimes for many months and years. So we know that drugs have the potential to cause lasting changes. We don't know whether those changes disappear in the end, get back to normal or not. And it seems that maybe in some cases it at least takes a long time for those changes to get back to normal. So I think that's probably really what I wanted to say. Just again to stress that I think it's really important that we do publicize the fact that these drugs are not working by rectifying, reversing some underlying chemical imbalance or other abnormality, because I think this makes people so frightened about the possibility of coming off them, and it makes people underestimate their own resources and their own abilities to address problems.
Thank you, Joanna. That's really important, isn't it? And I can't help thinking that if we did adopt a drug-centered model in conversations with our prescribers about the difficulties of coming off, it would be a very different experience, wouldn't it? Because they wouldn't automatically leap to "you are relapsing." They would instead think this is a drug effect, and we need to talk about that.
Yep, absolutely.
Yeah, absolutely. Thank you. And last but by no means least, Giovanni. I wondered if we could talk a little bit about your. You have a proposed theoretical model on the mechanism that might explain why withdrawal effects occur. So I wonder if you could talk to us a little about that.
I'll try. You see, in my clinical work, I observe a number of manifestations related to antidepressant drugs, not only the withdrawal reactions. And I was looking for a model to explain and to put together these manifestations. And I found it in this, what is called the oppositional model of tolerance. What is about? Mark described very well, very clearly the fact that the action of antidepressants as well as other psychotropic drugs require adjustment, balances. For instance, everybody knows that antidepressants take at least 3 or 4 weeks to manifest their effects. There is this phase. And why does it take that time? Because there are some adjustments in the receptors that have to be made. Curiously, in psychopharmacology, you accept that things are different between 4 days or 4 weeks, but you assume that 4 weeks or 4 years of treatment are the same. I mean, nothing changes. So the model, what does the model postulates? And let me first of all clarify that it's a tentative explanation, that we very much need the research and tests and confirmation. So when you have a treatment that extends over several months or even more years, these medications may stimulate processes that run counter the initial acute effect of a drug. So they are sort of oppositional. For instance, you may have someone who's taking antidepressant drugs for several months, doing okay, and then what happens is that the drug stops making its effect. Or you may have the situation when the drug seems to be working too much, and then you get into behavioral activation, or you get into the opposite, paradoxical reactions, more depression or emotional numbing. Okay, so what happens in maintenance treatment gets augmented, amplified, if you decrease or discontinue the drug, the antidepressant drug, because these processes no longer have any oppositions. They become quite free. So that may be the case of withdrawal reactions, and may also be the case of withdrawal reactions that do not stop. One of, and we share with the speakers, with Mark, Joanna, and Peter, a long fight. It's not that for all people, after 2 weeks, everything is over. We wish it was the way. So they may continue for a long time. There may be other phenomena such as resistance to further treatment. And so we need to have this model to say that withdrawal reactions are part of a number of clinical manifestations that antidepressant drugs, like any other medication, may involve. I think that this is pretty much the basic idea. So the withdrawal reaction is the tip of the iceberg of a state of behavioral toxicity. These are the terms that we use, and it's not very easy to use these terms. Nonetheless, antidepressant drugs are very important and life-saving medication. This is simply a problem that you may encounter, and what makes things puzzling is that not in every patient, but in a part of patients, and we still need a lot of research, as I said, to understand better the phenomenon.
Thank you, Giovanni, and thank you all for going into that. So, just to kind of summarize, really, Giovanni talked to us about oppositional tolerance and the fact that the brain tries to oppose changes that are brought in by taking psychiatric drugs on a regular basis. Mark told us about why it's so important then to deal with those changes in a very gradual, incremental way downwards, so you're not shocking your brain and nervous system by making sudden changes that are then unopposed. And Peter talked to us a little bit about a practical method of making that slow and safe reduction by using tapering strips, and Joanne very kindly explained that our whole language and discussion and debate about this particular area is not particularly sophisticated. We're still very much focused on chemical imbalances and brain diseases and all the rest of it. That was very helpful, thank you. So I'd like to open it up to all of the panel now to to kind of pose some questions to you. And I guess the first one is, it's fantastic hearing about how much work has been done and how far we've come, but clearly there's a lot more still to do. So what are your thoughts about what are the most important areas of psychiatric drug withdrawal to focus our research on in the short to medium term?
Well, if I may, then given what Giovanni said, I think it's important to realize that there is this distinction between having withdrawal symptoms during tapering and having these withdrawal symptoms, or whatever you may call them, which occur after that. So there's a confusion in the literature that slower tapering doesn't prevent withdrawal. I think it can prevent withdrawal during tapering, but we still don't know in how far it can present withdrawal symptoms, or whatever you call it, post-acute withdrawal, or whichever name you give it, which occur weeks or even months later. I myself did an experiment, and it was actually published in Psychotherapy and Psychosomatics, in which I tapered the venlafaxine I used. And this was before the advent of tapering strips, but I knew I had to do it gradually. And during the tapering, everything went fine. It was only a few weeks after I stopped, I started having complaints again. I think 3 months later or 4 months later, I decided to start using antidepressants again, which I've been doing ever since because my complaints went away very quickly. Looking back, I think this points very much to things like withdrawal much more than the return of depression. But it leaves me with the question, what do I have to do to be able to stop using these antidepressants? Do I have to taper much more gradual than I did then? Or would I have to wait many months in sort of anguish, hoping that my complaints will go away in the near future sometime? And I think this is one of the crucial questions that we are facing, for me.
Thank you. Others' thoughts? What do we need to focus on?
So what I think we need to do is apply the sort of ideas that were started online about how to come off antidepressants, reducing by a small amount, seeing what happens to people, based on that making further reductions, with the idea that for some people who aren't for years, slowly means months or years rather than weeks, and see how many people can come off their drugs like that, what the range is for people, what the determinants of that are. Is it about how long you're on the drug? Is it about the type of drug you're on? Clearly some are worse than others. Is it about the way that your liver metabolizes that drug that causes it to affect your brain more? Is it some other genetic aspect? But I think a lot of the discussion in the published literature and in doctors' minds about tapering off antidepressants or other psychiatric drugs, they have in their mind that it takes days or weeks. And so they often conclude that people can't come off because they get into trouble when they taper over that period of time. Whereas if we change that time scale to months or years for some people, that might allow more people to come off, and for people to confuse withdrawal and relapse less, because I think that's one of the big issues. It can be very confusing for people because withdrawal can involve anxiety and depression. It seems to be able to involve psychotic symptoms when people come off antipsychotics. So the symptoms of withdrawal can look a lot like the symptoms of the underlying condition, which can make it very confusing for patients and can make it very confusing for doctors, and certainly compounded by doctors being told that relapse is very likely and withdrawal is not. Whereas I think if we do it slowly and monitor symptoms, we can see the difference between withdrawal and relapse by seeing that withdrawal comes, gets worse, gets better and goes away. And seeing that pattern again and again can be reassuring to the individual, and it can also let doctors know that what they're doing is about managing withdrawal symptoms, which means tapering more slowly rather than seeing relapse come back. So I think that's what we need to start doing, is tapering people off their drugs slowly and seeing how different people respond to that process.
Yeah, absolutely. And I assume there, part and parcel of that also is encouraging more information up front when these things are first prescribed, that people might have a considerable tapering journey in front of them, because I was never warned of that. Many people aren't. People end up staying on the drugs for 2 years, 5 years, 10 years. And of course, then they have the shock of finding out when it happens to them. So, I guess there's a big bit of work to do in terms of how do you give informed consent when we actually know really so little about what these drugs are doing in the brain and nervous system.
Well, we've done 2 studies asking people who have used the tapering strips how it went. And by the way, we have to do these studies. We can only ask them. We have no control over what happens in their daily clinical practice. And many of them have tried to taper medications before. And of those people, 70% were able to come off their medication. That was the first study, which tells me that if you allow patients to choose, because I think that's very much what happens in those circumstances, that it helps enormously without fixating on some kind of time people need. In the second study, we wanted to answer a different question. What happens to people once they have been able to come off their drug safely? And again, we came up with a percentage of something like 68%, I believe, of the people who had come off the medication, and they were still off the medication 1 year at least, up to 5 years. We could not measure any longer. So they did not start to use the medication again. And although it's difficult to know for certain, one of the things we saw that the people who had noted that they had had worse withdrawal symptoms during previous tapering attempts, they seemed to be a little bit more successful of staying off the medication. And although it's just sort of speculation, it was our feeling that they perhaps were more motivated to withstand the negative symptoms they were experiencing, because there was one thing they clearly did not want, and that was going back on the medication. And that brings in another component in this whole equation, and that are the social circumstances where people are in, the kind of support they have, the motivation they have. And that's definitely a factor we should also incorporate in our thinking about dealing with withdrawal issues.
Thank you, Peter. Giovanni, Joanna, any thoughts on where we should be investing our time and what little research money there is in this field?
Well, just to say, I think publicizing the existence of withdrawal effects like this meeting and others is so important. I mean, that's the first step. And I think it has really changed the discussion, certainly in the United Kingdom over the last few years. And it's so important to, point out to doctors what might be happening when people reduce medication or stop medication, but also in highlighting what we were saying, that, these are potentially dangerous drugs that we don't understand very much about. And what we don't understand is what they're doing to your brain. And if we can get that conversation started, then hopefully fewer people will start on the drugs in the first place, and doctors will be more willing to, will recognize the difficulties that people have when they're coming off and recognize them for what they are.
If I may add something, I think there are important steps that have been made, but there are further steps that need to be done. I think a very important step was the recognition of withdrawal syndromes and reactions from antidepressant drugs. And these occur very recently. I mean, let's think that in the UK, only in the current issue of the British Journal of Psychiatry, there is an acknowledgement of withdrawal reactions. And of course, they may seem similar to relapses, but there is a way of differentiating them. Withdrawal reactions are generally new symptoms that the patient didn't have before. So in the UK, in other European countries, the issue is getting recognition. In the United States, very little, I must say. And a couple of years ago, John Reed, Mark, and I had some controversy in the American Journal of Psychiatry about the paper that was published. So I think it is at least an important step that physicians start recognizing and acknowledging withdrawal syndromes. But of course, we need many, many more data on the long-term outcome of these syndromes. We now have instruments to measure, to evaluate. We need neurobiological studies that may disclose why a patient is having symptoms and another one is not having. There should be a reason. So, as I said before, we need this to be really a top priority in health research. And the last type of research we need are randomized controlled trials, which compare different methods of tapering, of discontinuing, of addressing the symptoms. And I think that through this effort, and maybe the time is ripe now, and it wasn't certainly, I can assure you, ripe when I started in the 90s. That was very, very tough. But the time is ripe for some sound research on these neglected topics.
Yeah, absolutely. Thank you. That was really helpful. And I'm going to pose you all a completely unfair question with just a few minutes to go before we go to viewers' questions. But you all talked in various parts about the neurobiology of withdrawal and, you know, how little we understand. And, you know, it's at the crux of it, isn't it? It's the age-old question of why do some people experience withdrawal? Why do some people not? Why does it start after someone's tapered with some people, but during the taper for others? You know, how do we know whether brain receptors will reset after they've been exposed for a period of time? So, you know, I just wanted your thoughts on what does the future look like in terms of how do we get to understand the detail of what is happening in a person's brain or nervous system when they take these drugs. So, you know, I know there's certain scanning and sampling you can do, and I know that there are certain models, but, you know, what does the future look like? Will we ever get to a point where we really can accurately model what the effect is on a person's brain and nervous system of taking these drugs over a period of time?
I think it will be very, very difficult. Yeah.
So I think number one, I think Joanna's point is the most important. That the first thing is acknowledging that these drugs, you know, have withdrawal effects and all sorts of other effects on the brain. We should be much more cautious in prescribing them. You know, I think maybe it's sometimes lost on people that a lot of the reasons that these drugs are in guidelines is because they prevent relapse. You know, for example, for antidepressants, the studies go for 6 weeks and show very small effects compared to placebo. But the reason why they're in the guidelines for 2 years or more is because they're supposed to prevent relapse. But the studies that show that they prevent relapse involve people being taken off the drugs, often in a few days, sometimes in 1 day, and then measuring symptoms in the few months afterwards. None of those studies look at withdrawal symptoms. So it's almost certain that a lot of those relapses are actually withdrawal effects. And so a lot of these drugs don't have the relapse prevention properties that they're said to have. And that means that the guidelines are suggesting the use of drugs based on very poor evidence. So I think the first step is to acknowledge withdrawal from all these drugs means that the relapse prevention properties, a lot of these drugs are exaggerated and means that we shouldn't be prescribing them for long periods of time. Then to answer your actual question, you know, I think Peter Gruder said this also before. You don't need to understand all the details of this in order to get people off safely. I think we certainly shouldn't wait around for brain scans before we try to work out how to get people off safely. I think the broad principles about doing it slowly do seem to apply to most people. But if you did want to look at what the effects on the brain are, then we have a wide array of imaging techniques that are currently used mostly to understand what people think are psychiatric illnesses, but could be deployed to look at the effect of the drugs on the brain, from imaging different receptors. You can image the serotonin receptor, you can image the serotonin transporter, you can image the benzodiazepine receptors, you can image dopamine receptors. So you can see a lot of different things in the brain, and you can see how they're affected by long-term use. Most effort hasn't been directed to look at those kinds of things, but it could be done. It could be, you could see what is happening as people lower their dose, and you could start to understand why are some people affected more. Is it because they've got more sensitive receptors? Is it because they simply have more of the drug available in their bodies because they're not getting rid of it as quickly through their kidneys and liver? So there are lots of things that could give us clues about why some people are affected more than others.
That's helpful. Thank you, Mark. And I guess the crux of this for so many people is, how do we best understand whether, given this oppositional tolerance mechanism, how do we best understand how people's brain receptors can reset after exposure, and how do we help that to happen in the quickest, best, most easy way for people, to try and avoid some of the protracted and ongoing problems that some people experience.
I would very much like to ask a question to Giovanni, because I'm less a proponent of RCTs, although I know they are very important instruments. But my problem with RCTs in withdrawal research is that it easily boils down to comparing two different tapering schedules with each other. And for me, this poses a sort of an ethical and a practical question, because what we've seen that we are successful with the tapering stick precisely because it's such a flexible system, and because people are able to choose themselves how slow or how fast they taper together with their prescriber. And if you are comparing two different tapering schedules in a group of people, you get group results. But you also know that some people will be treated wrongly because within this group, they need a completely different schedule than the one that is prescribed for a scientific reason. And it's difficult for me to envisage a clinical trial at this point in time, which is really answering questions and at the same time helping people to come off these drugs. Personally, I would favor at this point in time to do much more observational research, if only to get an idea of the enormous variation that is present in the group of patients we are dealing with. We have, I think, practically very little idea about that, even. So I would like to know how would you set up a clinical trial to answer these questions?
Okay, you see, randomized clinical trials provide answers that apply to the average patient. Yeah. And I agree with you that there is no solution which is good to everyone. I mean, each patient who comes to me has his or her own history of stress, medications, and you cannot simply do the process which is very common nowadays in psychiatry, make a diagnosis, and for the diagnosis you choose medications. Yeah. Nonetheless, we need to find out, and I also agree with you that we badly need observational studies to see what happens to these people, naturalistic studies. We need studies because these studies have been suppressed for many years. But at the same time, when we suggest a method, a way of handling a situation, we need to compare it with in a controlled way. Then, of course, we know that that doesn't mean that everything automatically applies to the patient in front of us. But it's such an important step and should be neglected. You see, it's evidence-based medicine, which is important, but has its own limitations. That's why in our journal we recently launched medicine-based evidence, which takes by leading American clinicians. One is the chair of medicine of Mass General Hospital in Boston, about looking at different profiles over time. So we need both randomized control trials and observational investigations.
Thank you all. That was very helpful. I'm going to move on now to ask some questions posed by the audience. And thank you, all of you, for raising your questions. I'm sorry we won't get through all of them, but we have a record of them all, and we'll try to make sure that any we don't get to today are built into future ones. And the first one, really, to start off with, someone's asked, can you talk a little about gradually decreasing antipsychotics and the associated symptoms of hearing voices and having unusual visual experiences? Do these disappear over time? Most of what I hear is about antidepressant withdrawal. And, I think that's important because, there is quite a focus on antidepressants because they're so commonly prescribed, but antipsychotic withdrawal is clearly very important too. So I wondered if anybody had any thoughts.
Well, there has been research, also Dutch studies. A very important one was in 2013 from Wondering. And in that study, they followed up patients for 7 years, patients who had either come off antipsychotics or had lowered the dose. And the surprising outcome of that study is that initially these patients seemed to fare, you could say, worse. They seemed to have more relapses. But after 7 years, a number of them fared better. Not necessarily that their symptoms were all gone away, but one way or another, they seemed to be capable to cope better with the symptoms, have a better quality of life. And this was true for the people who could stop completely, but also for a group of people who fared better by just lowering the dose. And what you can say is that also there it is very important, and for antipsychotics probably more than for antidepressants, that if you are lowering your dose, do it gradually, because if you get what people commonly experience as relapse in psychosis, is that people get into trouble the moment they stop. Relatives of people psychosis often say, no, don't stop using your antipsychotic because you will immediately get problems. I guess in many cases this will be what we call withdrawal. But apparently, at least for a part of the patient, it really seems to be possible to go off this medication or to lower the dose. We have to find out who. But the only way we can do it if we make it possible to do this gradually in a process between the provider and the patient, in which the patient has enough time to do it. And if there are all these other things in place that are also in. Thank
you, Peter. And Joanna and Mark, from the radar perspective, what are your thoughts?
So I think I think coming off antipsychotics is quite complex, and there are a number of things that could be happening. So One is that people experience withdrawal symptoms in the same way that people will get withdrawal symptoms if they come off benzodiazepines or opiates. And there is some evidence that occasionally those withdrawal symptoms can involve psychotic symptoms. And there is some evidence that some people who've never had psychotic symptoms before will develop them when they, in the period immediately after they stop taking antipsychotics. But there's also evidence that if you have had a mental health problem before, which involved psychotic symptoms, and that's why you were started on antipsychotics, that the process of coming off or stopping antipsychotics completely can increase the risk of having a subsequent relapse of your underlying problem. So your risk of having a relapse in the period during and after which you come off the medication may be higher than it was to begin with. And I think we definitely, I think as a clinician, I definitely do see this, that people do often seem to have a relapse which is similar to the episodes that they'd had in the past, but it seems more than just a coincidence that it's happened immediately after they stopped taking the medication. And it's that sort of problem that and the withdrawal symptoms that hopefully can be reduced by reducing the medication very slowly. But then there is a final possibility, that is that when you withdraw the medication, the underlying problem comes back. Maybe it was suppressed by the medication, because, you know, antipsychotics slow up people's thinking and blunt people's emotions and distance people from the sort of sensations. So I think another possibility is that you remove the medication and the underlying problem resurfaces. And I think all those things can be happening, and it's often very difficult to know which one is happening in any particular individual in any one time. But in order to give someone the best chance of avoiding all those different situations, reducing the medication slowly and carefully seems to be the best tactic. Mark, did you want to add to that?
Yes, I think that's a good, exactly. I think one thing, there's a study that was published last year that showed that people who tapered over greater than 40 weeks from their antipsychotic, so a year or more, had about a third the chance of relapsing of people who tapered over less than 10 weeks. So the slower you do it, the less chance there seems to be of relapsing. And so exactly to avoid all the different sorts of problems, the slower you do it, the better it seems to be to avoid a big change to your brain. And in relation to the specific question, as Joanna said, that there are some cases published in the literature of people with no psychotic disorder who experienced the symptoms that were mentioned. So there's a case of a lawyer who was on an antipsychotic for breast milk production, who, when she stopped it, had visual hallucinations and auditory hallucinations, heard voices and saw things, that lasted for 10 months after she'd been on the drug for 10 months. And she had to restart the drug again in order to stop those symptoms and had to come off it more slowly. And there's a handful of such cases. So it is possible that withdrawal symptoms from antipsychotics can involve psychotic symptoms. Though, of course, as Joanna said, reasonably, there are lots of other explanations as well.
Can I just add something? I've just seen we've got Martin Harrow in the audience. So hello, Martin. Honoured to be presenting to you. And Martin Harrow's work, as well as some other work that's coming out, suggests that people who avoid taking long-term antipsychotics can have a better outcome than people who take them continuously. And I think often it's and the really interesting thing about Martin's work is it shows that the benefits only seem to start to appear after about 4 years or so, and that fits with my experience. I would say that people can often have difficulties getting off antipsychotic medication, have a relapse, maybe have a relapse or two, have to go back on the medication. But, a bit like if you were coming off another sort of drug. But some people will finally manage to get off and manage well without the medication and actually manage better than they were managing when they were on it.
May I add something which I think is very important? That has to do with the uncertainty that there is inevitably present. For instance, for people on antipsychotics, we know that some people can stop successfully, some will struggle for a long time, and some perhaps not. And in my view, this is an argument for very careful tapering, because there are a lot of patients who want to find out. And given the insecurities that there are, if we allow patients to do this in a very careful manner, you don't have to say this will be the result, you will come off or you will not come off, but you have an opportunity to find out what the result will be in a safe and responsible way, rather than trying to determine at forehand you cannot taper and you can taper, because we basically cannot know. And it's patient right to have the opportunity to find out in the most careful way that is possible, I would say. You understand my point? Yeah, okay.
Thank you all. Thank you all. That was helpful. And we're getting on for time a little bit. So people are asking, does the length of time on a medication of some type influence how difficult withdrawal will be? And is there any way of working out for someone what the future might hold based upon how long they've been on a drug?
Well, I would say that you would expect that it makes a difference, but I think the real answer is that we basically don't really know if this is always true and for everybody. Again, you have big variation, and we need observational studies to find out.
So if I can share one slide, can't handle live without slides. I don't know if you can see that, but this is just putting together some of the studies that have been published for one antidepressant, and this is how long someone is on the drug for, the average in these different studies, and the chance of having withdrawal symptoms. And you can see that the longer you're on it, the more likely you are to have withdrawal symptoms. So if you're only on the drug for a few months, it's a rare occurrence, but once you're on it for more than 3 years, this is in months, then about 2/3 or 3/4 of people will have withdrawal symptoms. The same also applies, and this is from a smaller study, just asking people online. This also applies for severity. So these are people who say that the withdrawal symptoms that they experience are either moderately severe or severe. And so if you're only on them for a month or two, again, it's a rare thing to say. Once you're on it for more than 3 years, about 2/3 of patients will say that the symptoms were severe or moderately severe. And there's much less data on how long the symptoms last for. But it does seem that from the 5 studies that exist, that the longer you're on the drug for, the longer the symptoms will last for. So for people who are on the drug only for a few months, they get a few weeks of withdrawal symptoms. And once you're on it for a few years, it's more like months or longer for withdrawal symptoms. And so it might be that the longer you're on them, the more your brain gets used to the drug, the longer it takes for your brain to go back to its pre-refractory settings, and the longer and more severe and more likely withdrawal symptoms are.
Thank you. Giovanni?
If I may add something on this, yes, this is a general tendency that applies also to other manifestations of behavioral toxicity, such as loss of clinical effect. The longer the duration of treatment, the more likely is the antidepressant tendency to stop being effective. And this brings two very important points, in my opinion. One, that unlike what is the general tendency today, we need to use antidepressants for the shortest possible times. Of course, with antidepressants, it takes 3 months to get a full effect. So short cannot be less than a few months. But this is exactly the contrary of what is practiced. Longer and longer treatment. And as Mark was saying, then the evidence supporting this practice is really very, very little because of the confusion between relapse and withdrawal. And the other issue, which we should not be forgetting, is the role of psychotherapy in addressing symptoms that antidepressants are affecting. And I think we have very good data that if you perform in the sequential model, if you perform psychotherapy after pharmacotherapy, it may be it's not that important continuation of antidepressant drugs. So, but again, this is a general tendency. And then you may have a patient who has been taking paroxetine for 4 years who doesn't have withdrawal symptoms. And you wonder why. And you have a patient who has been taking paroxetine. I'm using paroxetine as an example because it's probably the worst antidepressant in causing these problems. And you may have a patient who's been taking paroxetine for 2 months, and you say, okay, I'm pretty safe in taking the medication off, and you encounter problems.
No.
So again, let's not forget that these are general tendencies that may vary with individual histories.
Absolutely. Yep. Thank you. Thank you. That's really helpful. And I guess tied to that then, you know, another viewer has asked, is there a relationship between the half-life of the drug you're taking and the amount of time you might need to taper off it?
My guess is yes. But anyway, as we see for paroxetine and venlafaxine, it's clear that people are choosing for longer times to taper than for other drugs. But also there you have these individual differences. And it has never been investigated very well in the way we can do now, because people are really able now to taper gradually using tapering strips. So we are still gathering data. So I think there is an association. Yeah, clearly.
So I've seen references in some mainly personal accounts that those people taking shorter half-life drugs, withdrawal tends to occur more quickly and hits them harder earlier on than drugs with very long half-lives like Prozac, for example. And people sometimes recommend a Prozac bridge for those people that are on short half-life drugs. So is that your experience too? And the people that you've dealt with, are the shorter half-life drugs more of a problem?
I think so, yes. But we also have questionnaires from people who have filled in, and they note that they've tried to taper off fluoxetine and had suffered much from withdrawal. And they use tapering strips, and it worked much better, which is very difficult to explain if you only look at the half-life and the receptor occupancy. And I don't see a reason not to believe those patients. So these are still open questions, I think. But in general, yes, surely, the shorter the half-life, the easier you will have problems. I mean, I still, if I forget one daily dose, I have a lousy day. I don't bother about it because now I know the solution. But when it first happened to me, it made me afraid. My depression coming back, and I wasn't born for this. So the moment I found out, it was relief. And this is absolutely reproducible. And it is within a single day. So, yes.
Giovanni?
Yes, of course, paroxetine and venlafaxine in comparative studies are the drugs which are most likely to cause withdrawal reactions. However, these reactions take place with any type of antidepressant.
Yep.
I mean, it's not only with short half-life. And let me also like to hear what Mark has to say about this, but let me point to a fact that the suggestion of shifting to fluoxetine, which in comparative studies were shown to produce few side effects, is totally devoid of any scientific evidence.
Evidence, yes.
There is I mean, the idea, and according to my model, actually shifting to fluoxetine, to another antidepressant, is also likely, at least potentially, to make things worse, because you're still using an antidepressant. So you're still feeding the oppositional process. Don't know, Mark, what you think.
Well, I've got a comment on that, and that is that shifting from venlafaxine to fluoxetine, if you do this in the wrong way, and I've seen schedules on the internet where they say you taper down from, if you use 150, you go to 112.5, you go to 75, you go to 37.5, the lowest dose, then you stop, and then you start taking your first fluoxetine. But given the extremely long half-life of the fluoxetine, it takes a few weeks before you have a reasonable steady state. And in this period of time, you will suffer terrible withdrawal from the venlafaxine. So even without the oppositional model of tolerance, you get immediate withdrawal symptoms if you don't do the shift properly. And I think this is what happens in clinical practice probably quite often.
So I think, so after I think withdrawal is reported from all antidepressants, people on fluoxetine as well as people on paroxetine. So I think a long half-life doesn't protect you. It does seem that it's more common in the shorter half-life drugs like paroxetine, venlafaxine, and duloxetine. But it's true that those drugs also affect more receptors, so that's maybe part of the reason why they cause worse withdrawal. It does make some sense if you think about your brain is used to a drug, and it takes time for it to get back to normal, and having a drug that leaves your system more slowly would seem to reduce withdrawal rather than one that kind of comes out very quickly, and you've got more time delayed for the brain to go back to normal. So the textbooks still do recommend a fluoxetine switch, and I think if I was at gunpoint to choose an antidepressant for somebody, I would choose fluoxetine because it's easier to come off, I think, than other drugs. Although it can be a bit confusing because it has a half-life of about 2 weeks. You can experience withdrawal symptoms that are 3 or 4 months down the track, and it can be very confusing to connect that to coming off the drug. So it can be a confusing drug to come off, although it should make things more smooth. And so sometimes people can halve that drug every couple of months. When it comes to switching patients, I never switch patients. And I'll tell you that the textbook in the UK that guides drug use is the Maudsley Guidelines. The author of that tried the switch and was so unwell, he had to go back. So I think that switching causes a huge amount of trouble for people because you've got withdrawal from the one drug, you've got new side effects from the next drug. I think it is complicated. So if possible, I try to avoid that and just reduce the drug the person's already on. But then I've heard people say that they switch without problems. That makes it easier, but I think it's a bit risky in my experience.
Thank you. Thank you all. I'm conscious that we're coming up for time. There were a few questions bundled around tapering strips, but I'm sure Peter won't mind if I tell people go to taperingstrips.com, or it's taperingstrip.com, isn't it, on the web? Then questions should be.
There are also a number of other languages in which you have to search, like tapering strip DE for Germany, FR for France. So the information can be found in more languages than only in English.
Okay. And yeah, so thank you for your questions. I'm sorry we didn't get to too many of them, but we will keep them for future reference for future discussions. In the final minute or two, firstly, thank you all for attending this. We're delighted to have you with us, and thank you for spending the last hour and a half with us to talk about these issues. I wish we had more time, but we've packed in quite a lot, I think. Thank you so much to the panel for making time for this important discussion, and it's been great to see you and hear you talk about these developments and where we need to do more work and where we need to understand more. And thank you to Shira and Lucy for managing things behind the scenes. We will be arranging another upcoming discussion in this series. The next one, we're going to be focusing on protracted withdrawal experiences. So the experiences of people that have gone on to have very, very long-term problems after even gradual tapers. So keep an eye on madinamerica.com, and we'll be announcing details for that one within the next week or two. There will be a recording of this, and we will email you all a link to that when it's up on Mad in America's YouTube channel. But thank you to all of you for attending, and if any of the panel had any last words, over to you.
I just wanted to say in relation to the last point that I think it's really important people appreciate that drugs like antidepressants are not the same, but drugs like benzodiazepines are relatively chemically similar and have similar effects but different half-lives. But antidepressant drugs, even things that are labeled as SSRIs, are different from each other, and that's why I think the switching is difficult. And antipsychotics are even more varied. They're drugs with all sorts of different actions, so switching is definitely complicated.
Well, and if you want to switch, you should try to do it in such a way that at least your receptor occupancy, because most of the switches are done between molecules which work on the same receptor, that you try to keep the receptor occupancy high enough to not get people into trouble. And for that purpose, it is possible to use switch strips, and we will be validating that if people switch. But I tend to agree with Mark. Why would you well, that's a matter of debate. But indeed, switching is difficult.
Okay, I'm going to have to call time to it there because we're just over time. Thank you all so much. It's been a great discussion and great to see you all, and we look forward to the next one.